Hey everyone, and welcome to the Flatlining podcast from Fulcrum Strategies. I'm Matthew Handley, and with me, as he usually is on these Wednesday episodes, is our president and CEO, Ron Howirgon. Ron, how are you, sir?
I am good, thank you.
We are going to be talking today about Medicare Advantage and the CMS, Centers for Medicare and Medicaid Services. There's been some stories published this week in Becker's that we want to talk about. But first, Ron, I want to talk about something that is important to a lot of us at Fulcrum because we're based in North Carolina, and a lot of patients in North Carolina because it affects one of the state's largest hospital systems, and that is UNC Health and UnitedHealthcare approaching their termination date of April 1. UNC Health has said that they've been negotiating in good faith. UnitedHealthcare says that, they want too much money, which is what we saw when they weren't non-par with WakeMed. I want to talk a little bit about why this is a typical strategy we see with, any system, big or small, with UnitedHealthcare, why it always seems to come down to the 11th hour with this particular payer.
Yeah, I think there's really two factors involved in why, the vast majority of the time, if you see a termination, whether it's a big medical group or a hospital, it's usually United more often than any of the rest of them. Now, it's not that it doesn't happen with the rest of them, but more often it happens with United. I think it's two factors. One is United's size. Pretty much in every state, they are the second largest payer to the BlueCross plans. The BlueCross plans tend to not like this termination strategy as much because of their status. But United is usually bigger than Aetna and Cigna. They're usually bigger than Aetna and Cigna put together. So you're dealing with more money. The other one is United is what I would call the most pure of the for-profit insurance companies. And what I mean by that is they seem to take their mandate, which in their eyes, and with all for-profit companies, is to maximize their shareholders' investment. Their job is not to make friends. It's not really even to, provide excellent healthcare. Their job is to increase their stock price and produce a return for their investors. So they take that probably the most strictly or the most pure of any of the for-profit carriers, and that means they're going to get into these disputes because they're trying to pay the absolute smallest amount of money they can. And on the other side, the hospitals are trying to get as much money as they can, or at least enough money to cover cost increases. So that's why we experience this. And whenever I see something like this, and I think about all the patients that are potentially impacted with this, it always reminds me of sort of that old adage that when elephants fight, only the grass gets hurt. And that's what's going to happen here if it actually goes to termination. There's some patients going to get hurt. Both organizations are going to survive it, and they'll eventually figure it out.
Now, it's important to remember, too, that if you're a patient, you have UnitedHealthcare, and there's an emergency situation, you can go to the emergency room at UNC Health, because we had that issue. You've talked about it before on this program, of the patient that drove past WakeMed, I believe, to go to Rex, not understanding that they could have gone to WakeMed in an emergency situation.
Yeah, the patient, it was many years ago, when there was a dispute. WakeMed was out of network, and there was a woman driving her husband who was having a heart attack. And she was concerned that she couldn't go to WakeMed, even though it was an emergency and it would have been covered. And she drove past WakeMed to Rex Hospital, and that's not that far away, but it's an extra drive. Mm-hmm. And he passed away in the parking lot. Yeah. Now, again, he may have passed away in the ER at WakeMed. There's no guarantee of that, right. But that's that unfortunate situation of patients don't understand necessarily the ins and outs of this. If you're a woman who's in her third trimester of pregnancy, you go, wait a minute, can I deliver there? Will that be covered? If you're a patient who's receiving cancer treatments and you're in the middle of those treatments, it's not as easy as just, let's say, shutting down a restaurant and saying, oh, you can't eat here tomorrow. Yeah. And that's what I mean by, that it's the grass that gets hurt.
Real quick, Ron, is the last thing on this particular topic, understanding that we are a little biased at Fulcrum Strategies because we are physician advocates. But we typically see, oftentimes the payers are better at playing the media game, I think, getting into the local television stations and the papers and talking about why this is really, say UNC Health's fault for these two groups going non-par. Talk a little bit about, just put it a little bit in perspective, is that why, one, you could probably say that no one's really at fault, and talk a little bit about why this is normal in the process.
Yeah, you're absolutely right. I mean, this is a large business contract, and in some ways, UnitedHealthcare is correct that if they increase their reimbursement to hospitals, premiums go up, costs go up for their self-funded employers. And UNC is correct to say we've had these massive increases in our costs. Somebody has to pay for them. So, they're sort of both at fault, and neither is at fault. But you're right. The payers historically have been a little bit better at playing the public relations game. United's very good at that. Like all for-profit companies are very good at that. And this isn't really other than the fact that it's healthcare, which makes it different. It's not that much different when what was going back and forth when the big auto manufacturers were in their, contract disputes with the UAW. Mm-hmm. And the workers are saying, I need more money to cover the cost of inflation. And you haven't given me a raise in this long. And the auto manufacturers are saying, well, I have to compete with the Japanese manufacturers and the Germans, and I can't do that to the price of the car. It'll affect the average American. I mean, all of that's true. But at the end of the day, this is about healthcare, and we have to be very careful about it. And it's hard personally, and this gets into the bias part, because we are biased since we're physician advocates. It's hard for me to shed too many tears for UnitedHealthcare, seeing how many billions of dollars they made last year. They're doing just fine, okay? There's nobody at United who's worried about not getting a bonus this year.
Yeah. Well, and as we switch gears, this is a great time for me to let everyone know that next week we're going to have a really good interview with Dr. Damian McHugh. He's an emergency medicine physician who is now working with Curie, a advocacy group based in Raleigh, North Carolina. And he's going to be talking about physician burnout. And one of those issues was talking about just that, the money issue of the fact that, after an instance like COVID-19, and we've talked about it before, physicians really kind of got a little bit of a middle finger from the federal government when they cut the Medicare fee schedule repeatedly since the pandemic. So we're going to have that conversation for you next week on the Flatlining podcast. So if you're not subscribed, make sure you're subscribed. You can also have them delivered to your email by going to flatlining.net and clicking the subscribe button there. All right, Ron, the main thing I wanted to talk about today was a press release issued by the Better Medicare Alliance. And the Better Medicare Alliance, for those of you that aren't aware, is an insurer-backed advocacy group. Essentially, they're a lobby group. They were criticizing the Centers for Medicare and Medicaid Services last week for rising utilization rates. And of course, as we know, rising utilization rates for Medicare Advantage means that these payers have to pay out more money to the physicians. The Better Medicare Alliance president, Mary Beth Donahue, said there have been a notable increase in seniors using healthcare services from their doctors and providers, which makes sense given the increasing aging population and the pent-up demand after COVID. But at the same time, Medicare Advantage program continues to adjust to significant policy changes, including the implementation to major changes from Medicare Part D. So first, Ron, can you break down a little bit about what she's talking about here? What kind of policy changes are we seeing in the Medicare Advantage program, and what are the changes that we're seeing to Medicare Part D?
Yeah, well, the gist of it is that it's a group saying we need more money. That our costs are going up. Medicare people are using more services compared to COVID, obviously. Mm-hmm. And the Part D stuff has to do with some of the increased expenses for drugs that are being approved by Medicare. And we've talked about this a long time. Drug costs are, a huge problem across the whole industry. But it's basically them saying, look, you're approving more drugs, that increases our cost. You're making other policy changes on the things we have to cover, and we're just not making nearly enough money. And you should give us more money because we're doing so poorly. And you can tell by my voice the sarcasm that's starting to seep into my discussion. But that's the gist of it. Yeah. And they're trying to cry poor to Medicare, and that I find massively hypocritical.
It's interesting too, because my first thought that I went to is, and I understand that Medicare Advantage is incredibly. Most patients who have a Medicare Advantage plan are generally very satisfied with their Medicare Advantage plan. Mm-hmm. Flying back from our meeting yesterday or last week in Raleigh for our staff meeting, Ron, I had sat next to someone who I got talking to only because I have a client in the town where she lives. And she was talking about how she liked her Medicare Advantage and that she doesn't have a copay or deductible or, a regular monthly premium. And so my first thought in this particular instance is, could it be that they are, because they have all those things for commercial insurers, could it be that that is one of the reasons they're losing out money? Because for seniors who rightfully need health care, that there's more utilization because they are not having to pay out of pocket for it.
Well, there definitely is a potential there. There's a strong correlation between the lowering the amount of out of pocket a patient would pay for something and increased utilization. Now, the question that everybody has in that is, well, is that good or bad? In other words, if we increase out of pocket, if we have deductibles, copays, coinsurance, does that mean people will not seek care when they should have, let's say earlier on? And getting ahead of something is better and lowers overall cost. So, and it's probably a mix of both. There's probably some unnecessary utilization happens when it's free. And there's probably some utilization that should happen for preventative services or early things if it's expensive, that doesn't happen. So probably some of that there. But to me, the bigger sort of question in this is, and again, first of all, Medicare Advantage has been an amazing thing for the individuals who are covered by it. Taking these seniors and getting rid of coinsurance and copays and all that other stuff, massively helpful, especially for those seniors who are on fixed income, et cetera. So no dispute there. The question becomes, is it at the expense of the federal budget by lining the pockets of insurance companies or not? Now, the reality is, even with these reduced earnings that happened with coming out of COVID for 2022 and now looking at 2023, Medicare Advantage on a per enrollee basis is still the most profitable line of insurance that these companies sell. It's about twice as profitable as Medicaid, managed Medicaid, and about 45% more profitable than, let's say, employer or commercial risk. So when they whine about me needing more money, yes, their earnings, both per individual and their margin overall, has gone down as people have come out of COVID and started using it. But it is still the most profitable thing they sell. Their problem is that Wall Street wants it to continue to be at the profit they made during COVID.
Right.
And it will put pressure on their earnings if it goes down. And so, but I mean, again, to me, the hypocrisy is that, whining about this and saying, well, our profits are being diminished. There aren't any physicians out there who see Medicare patients who think they're profitable. They're not. They see Medicare as a social mission.
Yeah.
But Medicare on the physician level almost universally is below their cost. So, they would like to break even. And the insurance companies are whining about, well, we're only making $500 of profit per enrollee per year. Physicians will kill just to break even.
Right. Yeah. And just speaking generally, we've seen all these Medicare Advantage contracts that are either at Medicare rates or even below Medicare rates. They would make more money if they weren't on a, UnitedHealthcare Medicare Advantage card. Right. And to anyone who's interested in seeing the evidence that Medicare Advantage is significantly more profitable than the commercial insurance, just take a look at Humana. They dropped all of their commercial insurance on January 1 of this year to focus solely on their government products, which includes Medicare Advantage as the main one, plus some Medicaid, and then they also they run TRICARE on the in the east part of the United States. Ron, let me play a little bit of devil's advocate here. When we think about Medicare Advantage and the benefits that it has for patients, I think a lot of these payers also would argue that they provide a benefit to the federal government and by extension to the taxpayer because they're more efficient at handling claims. They're more efficient at paying out to providers. And in fact, there were several studies towards the end of last year that showed that the patients on Medicare Advantage had lower utilization than patients on traditional Medicare. So with that, thinking about that and the idea of these payers saying and really whining that they need more money, what would you say to something like that? That they do provide a service to the taxpayer because of that?
So, and I do think to some degree that's true. I think they do. There's definitely some studies out there that show that whatever the process of medical management or et cetera that the payers use has a reduction in utilization. It's the same theory as to why managed care came into the employer arena versus the old indemnity insurance. It's the same the reason why states pursue managed Medicaid. And to be intellectually honest, I think there is some value there. My issue isn't so much that, that Medicare Advantage is a negative in total for the taxpayers. My issue is we've gotten this sort of, if you think about different pieces of the whole healthcare component, it's now disjointed. Pharma does pretty well on Medicare. Okay. Hospitals do better than physicians on Medicare. And they actually got an increase last year when physicians got cut. Payers clearly do very well on Medicare. And I'm not one that says they should do it as a social mission. If they're going to take risk, they're going to sell the product, they should make the profit. Now, I could argue that should they be making 45% more profit than they make on their employer groups? Maybe not. Maybe that's too much. But we've got three components: pharma, hospitals, and payers who are either doing very well or doing better. And then we've got physicians being crushed. And so that disjointed part is the part I have a problem with here when they're whining about money when physicians are taking massive cuts. And then I go back to the thing about, what? Without the doctor, none of the rest of this works. Without the doctor providing the care, who cares what your insurance card is? I mean, if there are no doctors who are willing to take it, your Medicare Advantage card will suddenly be like a gift certificate at Blockbuster video rentals.
Right.
Who cares?
Yeah.
And if, and hospitals without physicians are really just expensive hotels with bad food. So, we're doing all of this stuff and pharma can't, fill a prescription until a doctor writes it. So that's my problem with them whining about their money is, boy, you're killing the entity that makes all of this possible, the doctor. And nobody seems to care.
Well, and even going back to what we just talked about with UNC Health and the statements that UnitedHealthcare has made about, they're asking for too much money, they're going to drive up premiums for all their patients, and comparing that to what you said at the beginning of this segment, UnitedHealthcare made billions of dollars in profit last year, not just income, but profit that was then paid out to their executives and shareholders.
Yeah, I mean, 24 billion dollars in profit. And the other, and I know this is a little bit of a side, but what a lot of people don't understand is, UnitedHealthcare currently employs about 10% of all the practicing physicians in this country. 1 out of 10. They own over 200 ambulatory surgery centers. They own a huge PBM. They are starting to become this massively integrated healthcare driving force. And I'm sure there are a lot of people who think that's not necessarily a great thing.
Yeah, I saw a chart the other day that had them listed somewhere. I don't remember where it is, but it was in the top 10 of the largest companies in the world was UnitedHealthcare.
Yeah,
in that too, you see them investing in other medical, physician groups and other payer-like institutions in other countries as well. But that's a topic for another day. Let me switch gears a little bit, and we'll talk about payers behaving badly, particularly with Medicare Advantage. And for this story, we're going to New Hampshire. And in New Hampshire, Elevance, which owns Anthem, BlueCross, BlueShield in that state, they took over the state's Medicare Advantage plan for state retirees at the beginning of this year. Well, according to their contract with the state, this was published by the state, by the New Hampshire Union Leader, one of the newspapers there, Anthem must ship 98% of its mail order prescriptions within 2 days of getting the prescription. So this is using the payer-owned pharmacy. Each quarter that it fails to meet that standard, Anthem can be fined $50,000 for each percentage point under 98%. It appears, according to reporting from New Hampshire Public Radio and the New Hampshire Union Leader, that they have massively screwed up their mail order pharmacy for their patients, and it appears that they're going to be fined a significant amount of money. I don't see a dollar amount in this particular article. They're going to be fined a significant amount of money by the state. So, Ron, first of all, I want to talk a little bit about, because we were just talking about Medicare Advantage and all the benefits that it has. For some of these Medicare Advantage plans, like this one, is it that only the patients can only use Anthem's mail order pharmacy? And if so, how do patients, how is that allowed when it might be easier and perhaps more efficient to go to a local pharmacy around the corner?
So usually, and I don't know the details about this particular Anthem, usually it's not that you must use the mail order pharmacy. If anything, there sometimes are a financial incentive to use it. You can get, you get 90 days of mail order for for a $10 copay
Sure.
versus 30 days at the local pharmacy. But I've not seen anywhere where you must only use the mail order. Okay, but here's the problem, and this is why this is. And I'm glad the state's fining them. If they screwed up, they deserve to be fined. But it can be worse than that. You've got a lot of these seniors who rely on that mail order because they would really have a hard time getting to the pharmacy. Especially think about winters in New Hampshire.
Yes.
Okay. So, and we know that missing these meds is not good. So the question that hit my mind when I first saw this was, well, how many people didn't get their drugs, expected them? And then once they didn't show up in the mail, they're probably saying, well, they'll be here tomorrow. I don't want to go to the pharmacy because the prescription's already been put through mail order. That can be a problem. Or I can't get to the pharmacy. What responsibility or culpability does a corporation have when there is a bad outcome or a patient who, because they were off their meds for certain days, had some sort of event, et cetera? That's, to me, another big piece of this. So I'm glad they're getting fined. I'm glad the contract said you must do this within this time frame.
Yeah.
But what I don't think being discussed well enough, what happened about poor Mrs. Smith who didn't get her, this medicine? I mean, who's responsible for that? And what happens? Because I'm sure that money doesn't go down to her. That's to me the real problem.
Well, and it's just to put this a little bit perspective, this is not a small Medicare Advantage plan. I mean, it's 11,000 retired New Hampshire state employees. The meeting of the state's executive council said that they will be leveraging penalties against Anthem. And a spokesperson said this for the state, to give credit where credit's due. He said the medical side of the contract has been fine, but the prescription drug coverage has been a disaster. He said the contract and the implementation of it is a massively screwed up, and the company that's implementing the new contract is doing a horrible job, and it's not getting better fast enough. Of course, Anthem, their spokesman said that they were disappointed in statements like that, but surprise, surprise. Ron, we have in North Carolina, the state health plan switching from BlueCross BlueShield to Aetna, as it appears to be going right now. Does that include retirees in the state of North Carolina? Will they be on an Aetna Medicare Advantage plan, or do you know how their retirement program works, or if they even offer that in the state of North Carolina?
I'll be honest with you, I'm not sure. I've been so focused on the regular state employees, I'm not sure how that works. I think they have a retirement plan, but I'm not sure if that switch is included or if they offer choice there. Well,
then let me ask you this, because I know the other one I've seen probably the most is New York City has Aetna Medicare Advantage for their retirees. How common is it for municipalities, for states to have a Medicare Advantage plan for their retirees, something like this?
Well, it's much more common for states, municipalities, things like that, to have it than it is for regular employers.
Sure.
You and I both being, familiar with, and you living there now, and me having grown up in Michigan, know about the plight of the city of Detroit.
Oh, yeah.
And a big part of that problem was promises they had made and retirement, both for healthcare and pensions, et cetera, that, are the city's version of an unfunded mandate. So a lot of states and municipalities and cities and that kind of stuff have those kind of programs, and they create, significant issues. Typical employers usually don't.
Yeah. Do you have any other just brief reaction to this story in New Hampshire? Other than the fines, is there any sort of federal repercussions that, Elevance could face because it's a Medicare Advantage product?
Yeah, and we've seen this with other companies for different issues. We saw it with Cigna's HealthSpring, their Medicare product, where they got into some trouble, and the federal government pulled their license for a while and said, you can't sell this. So they can. The federal government could pull that Medicare Advantage license. They could suspend it for a while if things get really bad. And again, all those things are are good to keep these actors, following what they should be following. But again, I'll go back to, I know this is I'm beating a dead horse here, but at some point, since we're talking about healthcare here, and people can have really negative outcomes for failure by an insurance company, whether it's not sending drugs or, medical directors denying things they shouldn't deny or whatever it is, we've got to figure out a way to hold the insurance company individually responsible for what happens to an individual. A fine from the state or the federal government suspending your license doesn't help the family of somebody who has a negative outcome because they didn't get their meds, right, or couldn't get a service because it got denied by a medical director somewhere. That's the connection I would like to see start to happen. And I will tell you, if it happens, it'll also help and make these actors do the right thing from the beginning.
Well, if any of that happens, Ron, we're wrapping up because we're coming up on time for this program. If any of that happens, I'll be sure to ask you about it right here on the Flatlining Podcast. How does that sound?
Absolutely.
All right. Thank you, Ron. Miss an episode of the Flatlining Podcast? Well, now you can read a recap. Just go to flatlining.net and look right there on the homepage every Monday for a written recap on last week's episode.